This video touches on the topic of suicide. You might be coming to this video as a researcher or suicidologist who engages in this subject matter in your work, as a survivor of suicide or suicide loss who has been personally impacted by this subject, or as a policymaker looking to translate research into policy. However you're showing up today, the topic of suicide can evoke a deep pain and emotion. Before we begin, I'd like to start with a few grounding reminders, borrowed from Dr. Jeffrey Anslus. You may want to consider checking in with yourself to decide how and when to best watch this video. Maybe you want to watch it with other people. Maybe you want to watch it in the morning and not late at night. We invite you to bring a good heart, a good mind, and a lot of compassion for all as you watch, including yourself. Feel free to take a moment now to pause, reconnect with yourself, and reflect on how you plan on engaging with the content today. There are resources available to you should you want to talk to someone. Depending on where you are in the world, those resources may look different. In the description of this video, we've provided some places to start, with options to get help for yourself and help with supporting someone else.
Hello, everybody. Welcome to the Asynchronous seminar for the Methods Core seminar series. Today, we're going to be presenting on analytic methods considerations in suicide research. I am Andrew Rogers. I'm a clinical psychologist, and I am on the Methods Core as a quantitative consultant, provide statistical guidance on intensive longitudinal studies and clinical trials, and my research interests are in pain, substance use, chronic illness, and adolescents and young adults.
I'm Kevin Holgren. I'm a clinical psychologist as well, and also a methods or quantitative methods consultant. Here, like Andrew, to provide stats guidance on trials and observational studies and the research that you might do through the methods core or stemming out of the methods core. Personally, my research interests focus on substance use disorder treatment, including the development, implementation, and study of health services for substance use disorders. Today, Andrew and I are going to co-present, and our agenda for the presentation here is on the slide today. The purpose of the presentation we'll go over, and then we'll talk about outcome distributions that you may need to consider for different kinds of measures that you may be studying in your research, and regression frameworks to handle different kinds of outcomes. Andrew will also talk about clustered data and how to handle that, or considerations for handling that. I'll talk about statistical power and planning for power analyses, followed by considerations for missing data. To give an overview of what our purpose is today, we hope that this presentation will give you an overview of issues that you can consider when you're using quantitative methods in SCRC projects. This will be more like a refresher on issues that are relevant across the research cycle, which includes considerations that you might want to keep in mind while you're writing grants, while you're designing studies, writing up data analytic plans, conducting your analyses, reporting your findings, or even reviewing other studies and planning for future grants. Where possible, we provided references to relevant literature so that you can explore some of these topics with greater depth if this didn't give you enough information off the bat. And to be clear about what we're not hoping this presentation will be, we are not designing this presentation to be a definitive source on which analytic methods you should use or which analytic methods are best for your particular research design. And this also isn't meant to function as a tutorial or a how-to guide, and we don't go into things like computational details of how to run these analyses. However, we are going to be available for consultation to help you with these kinds of questions and support on these topics. And keep in mind that we will be offering future resources through the methods core, including a live synchronous presentation on pre-specification of data analytic plans, and that will be coming in May 2024. And we're also developing a tool to help guide researchers on recommended and/or required analytic approaches for specific types of measures and specific types of study designs. This will essentially function as a guide to help you know which analytic methods are appropriate for different kinds of study designs. So also be on the lookout for this. And Andrew will talk about outcome distributions.
Great. Thank you, Kevin. So when thinking about suicide research, it's important for us to consider the outcomes of the variables that we're examining and how these outcome distributions may guide our analytic choices. Again, this is not a how-to guide, but for a sort of a guide for you to be thinking about what models you want to use as you begin to explore your data. So the first type of model that we're going to talk about is a linear model, something we can use for a truly continuous measure or a measure that could be approximated on a continuous scale. As we see here in this example, something like the PHQ-9, which measures depression. Questions you can answer with linear models include things like what predicts depression severity, and you would see that depression severity typically falls in sort of a normally distributed pattern. The outcomes can be interpreted with effect sizes, and effect sizes in linear models can include things like eta or partial eta squared, or Cohen's d. A second type of model and outcome we want to be thinking about is a binary or logistic model. This is going to be when your research question involves an outcome that has two options. As an example here, have you made a suicide attempt in the past 6 months? Yes or no. So you have these two choices, and you use the logistic model to model the probability of having one of the outcomes, which is expressed as an odds ratio. Ways to interpret this include the magnitude of results, such as this variable might increase the odds of making a suicide attempt by 4. Another possible outcome that you might want to consider for a different model is a count model. So this is something where we may ask questions like, how many days did you stay in the hospital following a suicide attempt? We are seeing here, right, that each value, right, represents a number of days, right, not necessarily a continuous scale. The way that we can interpret count models, and in an effect size, we use something called a rate ratio to understand our count outcomes. I will come back to count outcomes in a moment, but before we do that, I'm also going to review survival or hazard models. These are models we use when we are interested in time as a factor and time as it relates to an event happening. So we might be interested in time from intervention to first inpatient admission, right? So survival models relate that the time that passes before an event occurs and relates that to one or more covariates. So if you're looking at a treatment, right, is there a difference in one treatment or another? A proportional hazards or a hazard model is the opposite of that, where we are interested in the unique effect of a unit increase in a covariate. So here's an example, right? Does taking a drug have one's hazard risk for having a stroke, right? So it's a little bit different, but they both are sort of related to something happening until an event occurs. I mentioned coming back to count models. Zero-inflated models are a type of count model, but where you are seeing sort of an overrepresentation of zeros. Right? So for instance, how many suicide attempts have you made in the last 6 months? You're going to see a significant number of zeros, and then some ones, and then the rest sort of greater than 1. There are a number of different ways that we can handle zero-inflated models. And as Kevin alluded to, this flow chart that we will be creating will sort of give a breakdown of the model choices to use and when to use them. But for now, we're going to give the overview that 3 potential models to use in zero-inflated models include a zero-inflated Poisson regression, zero-inflated negative binomial regression, and a hurdle model. Not to go into details of these models specifically, but to give a general overview of why we need to use zero-inflated models and the benefits of using zero-inflated models, I want you to think about zero-inflated models are a combination of binary events and counts. meaning a combination of something happening, yes or no, plus the number of times something happens, right? So we might want to be looking at any suicide attempt, yes or no, and then the number of suicide attempts. And we see here that's sort of the difference between that 0 on the far left, as well as all the values that follow to the right. It does model these things simultaneously, right? We're not going to lose any information by either dichotomizing and using a logistic model or using the count model. We can use both. And when you run a zero inflated model, you'll get effect sizes for the 0 versus 1 as an odds ratio from the binary logistic model, and a separate effect size for the count outcome, including a rate ratio. So that was my overview of potential outcome distributions and models that you may encounter when looking at your data. Another thing that we want to be considering is data clustering. So clustering, just to give you an overview of what it is and when it is important, clustering is related when there are systematic sources of variance in your outcome that must be modeled. And I'll give an example in just a moment. But clustered data can arise when there are different groups that can classify the data. So for instance, patients within clinics, students within schools, and we consider these clusters to be nested. So we consider patients to be nested within clinics, and we consider students to be nested within schools, right? And so clustering matters, and I'm going to show in a moment an example of what clustering looks like. But clustering matters when there's high within group correlation or an interclass correlation, which means that people within a cluster are more similar to each other than those in another cluster. If that's the case, and we see this high interclass correlation, we're going to make sure that we are considering and modeling clustering. As an example here on the left, we see what the data looks like when we don't consider clustering. And then on the right, we see where the clusters lie. The data is the same, but it is clustered differently, right? And these relationships may differ. The relationship in the whole data set might be different than the relationships within each cluster. And so if you are seeing high interclass correlation, we are going to make sure that we model clusters in our data. When modeling clustered data, there are a few ways to handle clustered data. And of course, we're not going to go into the weeds about how to use them or which is best for a specific study. But to give a general overview, we have cluster robust standard errors, generalized estimating equations, and linear mixed effects models. And so when error terms are correlated within clusters, but are independent across clusters, right? Then we would use something like a cluster robust standard error. For generalized estimating equations, we are going to be using that when cluster data is non-normal, such as binary or count data. And then multi-level modeling or linear mixed effects models can handle clustered data in different ways as well, and is a very robust tool for handling different types of models. The caution that we will give you about combining clustering like a mixed effects model with a complex outcome distribution can get complex very quickly and are easy to make mistakes and get stuck in. So we encourage you to consult with Methods Core faculty when you are interested in a complicated clustered model. And now I'm going to turn it over to Kevin, who's going to talk about power and missing data.
So we'll start by talking about statistical power. And first of all, talking about what is power and what is a power analysis. Power is the probability that a study will correctly reject the null hypothesis when that null hypothesis is false. An example is, what is the probability that in my study, I will detect a significant reduction in suicidal ideation if in my trial, the intervention I'm testing is truly effective at reducing suicidal ideation. Power analysis is a calculation that we do to estimate the power of a study. And we conduct that power analysis based on a particular study design, like a randomized clinical trial, the sample size, and the anticipated effect size of the intervention or effect that we're looking for. Ideally, we do a power analysis a priori, meaning before we collect the data, as part of a grant application or during the initial study design phase. And in this case, you typically will use a power analysis to help inform the sample size that you shoot for when you're trying to collect your data in your study. So let's talk about things that increase power. There are a few things that you can do to increase power in your study. One is obtain a larger effect size. So if you're testing an intervention that produces a larger difference in the means of suicidal ideation between your treatment and control group, that's a larger signal, that's a larger effect size, and you will have higher power to detect that difference. You can also get a larger effect size by reducing the variance in the outcome that you're measuring. So for example, if there's less variability between individuals on suicidal ideation, there's less noise or less error variability in that outcome as well. And the effect size will be effect will be easier to detect. You'll be more highly powered. Sometimes those things can be controlled in your studies, for example, by testing a more potent intervention to try and increase the magnitude of the difference in the means, or by doing things that might adjust for or control for some of that variability, either in your sample selection to reduce the amount of variance in the outcome, or controlling for it with other variables in your model. Sometimes that's not always possible to do, though. So one other thing that you can do to increase your power in a study is to obtain a larger sample size. With a larger sample size, the precision of your effect estimates increases, meaning you get finer and finer estimates, less error in your estimates, and the ability to detect a significant effect also increases. And then lastly, power also depends on the alpha value that you select for your study. An alpha value is the threshold for determining that an effect is significant based on the p-value. For example, an alpha of 0.05 means that you would reject the null hypothesis if p is less than 0.05. Contrast that to an alpha level of 0.001. Studies that conduct more statistical tests that have more exploratory analyses will often need a lower p-value. And so keep in mind that that's something that can require a larger sample size in order to compensate for the lower p-value to retain your power. And for consideration of studies that use binary outcomes, particularly in suicide research, it's important to think about the base rate of the outcome that you're looking at. Power will be maximized when the base rate of the outcome that you're looking at is close to 50%. And it will be lower when the base rate of the outcome that you're looking at is closer to 0% or 100%. So for example, if your outcome was suicide attempt, if 50% of the sample was expected to experience a suicide attempt as the outcome, you would be more highly powered than if only 1% of the sample was expected to have a suicide attempt, because events that occur at very low base rates or very high base rates, close to 100%, are harder to detect. It's harder to detect a difference in that outcome. I'll illustrate this here with an example power analysis. This might be how you could illustrate a power analysis in a grant application. What is shown here is power on the y-axis. This is the probability of correctly rejecting the null hypothesis or correctly determining that there's a difference between group A and group B in risk for suicide attempt. 1.0 would mean 100% chance of rejecting the null hypothesis correctly. 0 would mean no chance that you would be powered to detect that. And on the x-axis is the potential sample sizes that you could recruit for your study. Each of the different lines represents a different base rate of the outcome. in group A and group B. The incidence of the outcome in group B is always twice as high in group A. So the risk ratio in each of these point estimates is 2, meaning that the base rate is higher, or I'm sorry, the incidence rate is twice as high in group B compared to group A. But the gray line represents a situation where the control condition has an incidence of 1%. So 1% of the sample has a suicide attempt. The orange group represents a 5% outcome for, for group A, and the blue line represents an incidence rate of 25%. And you'll see here the power is considerably lower when that base rate is rare compared to when the base rate is not rare, like in the blue group. So how do we estimate power? There's 3 general approaches that we can recommend. The first is the simplest, and that's to use a power table. And these are often published in textbooks and available online and very simple to use. And these are best for simple designs with commonly used statistics like t-tests to compare the mean difference in an outcome without covariate adjustment, or a chi-square test. To do this, you're typically looking for the desired level of power in your study, shown with the blue circle, and the anticipated effect size that you're trying to power for, which is in the red circle, 0.5. And then you look for where these 2 rows and columns intersect, and that is telling you the number of people that you need in your study in each condition to be adequately powered. So this would illustrate that we would need 85 subjects in each of the 2 groups to have 90% power for detecting a difference that has an effect size of d equals 0.5. Option B is to download power calculation software like GPower. GPower is a tool that I often use, but there are other software packages out there for estimating power, including special packages in R software and commands in Stata and other tools as well. A lot of these packages will have a point-and-click interface to make it easy to use. And these, again, are generally good for standardized methods that are commonly used, like a t-test, a chi-square test, logistic regression, ANOVA and ANCOVA, etc. And when you're using these, instead of looking at a chart, you type in what your anticipated effect size is and what level of power you're trying to achieve. And again, it tells you how many people were needed in each of the 2 groups. The third option is the hardest, and this is to use simulation methods. This is often the only realistic option when you're using a complex design, like a stepped wedge trial or a longitudinal design with numerous time points, like an ecological momentary assessment study, or a path model where you're testing numerous relationships and complicated associations between them. So often we have complicated models and we need to make a lot of educated guesses about the parameters in that model. And we make educated guesses about those parameters and generate or simulate data to represent plausible data sets that could be expected under the assumptions that you make of the relationships between those variables. And a number of data sets are simulated, and the significance of the effects that you're looking for is tested in each of those data sets to get an empirical estimate of the power of your study design. Fortunately, there are an increasing number of tools available online to help aid your power analysis with simulation designs. And we've linked to some examples here, some online calculators for stepped wedge cluster randomized trials, mediation analyses, structural equation models, and interactions and cross-sectional designs, just to name a few. Some recommended best practices for doing power analyses. Again, ideally, a power analysis should be conducted a priori as part of a grant application and/or in the initial study design phase to inform the study sample size decisions. We recommend estimating power across a range of potential scenarios. For example, plausible effect sizes of your intervention, because we don't know what the intervention effect size will be before we've done the study, as well as a range of sample sizes, because even though you may have one target sample size, Often we don't meet our recruitment goals, or we have the opportunities to exceed the recruitment goals, and it's good to know in advance what the power will be under different scenarios of recruitment. We also encourage you to remember that you can account for missing data in the power estimation stage. So for example, if we anticipate that 20% of people will be missing outcome analyses due to being lost at follow-up, then our recruited sample of 400 individuals actually represents a sample size of 320 people who will be included in the power analysis stage due to missing follow-up data. A lot of studies are necessarily underpowered by design, like like pilot studies. And we recommend that you state that upfront and clarify, make a clear case for why the study can still meet your objectives, even if it's underpowered. And then still do a power analysis to tell readers what level of effect sizes the pilot study would be capable of detecting potentially. So here's some example text that you can use, that we've used to help describe this. This pilot study is intentionally underpowered and is not intended to detect whether the intervention reduces suicidal ideation, but it will provide necessary information about feasibility, usability, and acceptability prior to a fully powered trial. Nonetheless, with our sample size of 30, we will have 80% power to detect a significant change in suicidal ideation if Cohen's d is greater than 1.06. We also encourage you to be a little bit cautious about power analyses in a few ways. First of all, the parameters that we enter into a power analysis are often best guesses, and we often don't know what they are in advance. Sometimes we can never know what they are, especially for complicated designs and studies that lack pilot data. So keep that in mind as a grain of salt. It is not ground truth when you do a power analysis. It's an estimation based on sometimes guesses as to what some of the effects or parameters will be. We also caution or echo people who have put out cautions about using effect size estimates from pilot studies to power your fully powered clinical trial, because estimates of effect sizes from small sample pilot studies are notoriously unreliable. And if you power your study based on an unreliable effect size estimate, you may be setting yourself up for failure in your trial. And we encourage you to read the paper linked below for more discussion of this. So instead of using an effect size from a pilot study to estimate power or do a power analysis for your fully powered trial, we recommend, and others recommend, defining an effect size that would represent a minimally clinically important difference, or MCID, and specifying that a priori, and then powering for that minimally clinically important difference. And what is an MCID? That is the smallest amount of improvement that your intervention could have in order to be considered meaningful to key individuals that would be impacted by this intervention. For example, what is the minimal effect size that would be important to patients, to clinicians, to a health system, to a payer, etc. Last, we'll talk about missing data. When we talk about missing data, we often talk about 3 different missing data mechanisms, meaning 3 different reasons why data could be missing from your study, because the approaches that we use for handling missing data can depend on the missing data mechanism. So the 3 missing data mechanisms we'll talk about today are missing completely at random, or MCAR, missing at random, MAR, and missing not at random, MNAR. The reason for your missing data, or the mechanism of the missing data, will have an impact on the validity of the results of your study, as well as the way that you try to accommodate missing data in your statistical analyses. So starting with MCAR, missing completely at random, this means that missingness in your outcome data, like participants not completing a follow-up, let's say, is not related to anything else in your study. It is completely random and unsystematic in any way. Another way of saying that is that all participants have an equal probability of having that missing outcome. So how could this ever happen in your research? Here are some hypothetical examples. Let's say a suicide ideation scale was accidentally omitted from a questionnaire packet or set of questionnaire packets for a random subset of people. Or let's say that due to limited funding and staff time, you randomly select only 20% of participants in your sample to complete an interview where you assess suicidal ideation or to pull their electronic health record data. Since we were able to randomly select who those individuals were, we could know that the data was missing completely at random in this example. The next missing data mechanism is MAR, or missing at random. In this case, missingness, not having the follow-up outcome, is only related to observable variables in your data set with non-missing data. Or another way of saying that is once those observed variables are accounted for statistically in your analysis, the probability of the data being missing or not missing is unrelated to the unobserved values that were missing themselves. So a hypothetical example of this would be, suppose that older adolescents have more missing follow-up data, and older adolescents have more severe suicidal ideation compared to younger adolescents in your study. We would expect that people with more missing data would therefore have a greater risk of suicidal ideation. So we don't have that suicidal ideation outcome, but we would expect that to be the case because older people are more often having suicidal ideation and more often missing data. This scenario would be considered missing, this should say MAR, not MCAR. Apologies for that, we'll fix that on the slides. The data would be considered MAR, missing at random, if the association between missingness and suicidal ideation severity were to disappear after controlling for age. So this is a thing that we actually can't know because that missing value of suicidal ideation for the older adolescents isn't present in our data set. So this is not something that we can empirically test in our study, but this could be the mechanism that explains why the missing data was present in the first place. So it's an underlying model, a latent model that we can't actually observe. The last scenario is missing not at random. In this case, missingness is related to the variables that were not measured, and that can include the missing values themselves. And this relationship would stay even if we were to control for the other observed variables like age in the last example. So one example of this would be participants with greater suicidal ideation severity, were more likely to miss their follow-up survey. And that wasn't just attributable to age or any other variables that we've observed in our data set. So some ways that we can handle missing data. The first, and unfortunately, one of the more common ways that people handle it is to just ignore it. And this can lead you to biased results, which is, of course, bad. Because the results are biased, but also bad to think about it in a way that people who are very important are no longer represented in the research despite taking the time to participate in the research and being intrinsically important and valued to be represented in the research that we do. Another way that it's often handled is to use an ad hoc or post hoc method that often seems very well-intentioned, but ultimately still leads to bias in the results, which is again bad. A third way is to use a recommended, empirically supported method to minimize bias and retain statistical power and precision of your estimates. We're calling these good approaches. So some of the bad ways that commonly get used. One is called complete case analysis. This is where people with missing outcome data are just excluded from the model. They get excluded from the analyses when you're examining that outcome. And this is the default in a lot of statistical software, to just remove people with missing data from the data set when running that particular analysis. And this will lead to biased results if your data are missing at random or missing not at random, but not if they're missing completely at random. Another well-intentioned but unfortunately biased method is to use what's called single value imputation. This means taking that missing value and making a guess, an informed guess as to what that value could have been, and inserting that into the data set and then running your model with it. So one example is to carry a baseline value forward. Take that baseline level of suicidal ideation severity and plug it in to the missing follow-up variable for that individual. Or take the most recent observation and carry that forward. Or assume the worst case. Let's quote unquote conservatively believe that if we are missing them, missing the outcome variable here. Let's just insert the worst case scenario that could have been there under the belief that this would give us a conservative estimate. Unfortunately, it doesn't give you a conservative estimate, and it gives you actually a very biased estimate. And this can be, this kind of single imputation approach can result in bias for any missing data mechanism and is really not recommended. Two good ways for handling missing data that we do recommend are to use multiple imputation and maximum likelihood methods. Again, we won't go into the details of how these work or how to do them, but we are happy to provide that kind of consultation. In brief, when you're using either of these methods, a statistical software program is going to reduce bias due to missing data by accounting for the observed correlations of the missing variables themselves, the variables with missing data, with all of the other variables that are observed in your data set, and arrive at a somewhat better estimate of what those values could have been if they were to be observed, while also accounting for the unknown factor. So not overestimating or making overly assured assumptions as to what those values would have been if they were measured. So for example, if we were missing a suicidal ideation severity score at follow-up for a number of people, we can recover some of the lost information based on that person's baseline suicidal ideation, as well as their age, their sex, depression severity at baseline, substance use at baseline, etc. So we would enter all of those things to help increase the precision of our final effect estimate, because we do have a lot of data about those individuals from their baseline measures. Multiple imputation and maximum likelihood will give you unbiased results if you have a missing completely at random or missing at random data mechanism. There will still be some bias if your missing data mechanism is missing not at random, but these methods can still reduce some of that bias. Some summary recommendations: try to minimize missing data, but plan for it to happen in any longitudinal study. And make plans a priori for quantifying missingness and for examining patterns to look at who might be more likely to have missing data to understand the reasons for missingness better. You will never know why your data are missing, whether it's due to missing completely at random, or missing not at random, but we can use clues from theory, clinical knowledge, those patterns of associations to make educated guesses as to what might be plausible reasons for the missingness, so that we can use a more informed approach. And we recommend using a modern method that's most likely to minimize bias across the widest range of scenarios whenever possible, like multiple imputation or maximum likelihood. And we'll wrap it up.
Thank you, Kevin. So as a wrap up, to just sort of go through what our goals of today were, is one, to provide you a menu of things to consider for quantitative studies that you are running. Keep in mind, this was not a how-to guide or even a which model to pick for your data, but that is related to some forthcoming resources in the SCRC, including information about pre-specifying data analysis plans and sort of a tool flowchart guide for recommended and required analytic approaches for specific measures and study designs that both Kevin and I will be talking about in an upcoming webinar. Thank you very much for your attention, and our contact information is here, and the slides will be posted for you to take a look at and click some of the links that we've provided.
Thank you for watching this seminar from the University of Washington Suicide Care Research Center. Please take a moment to complete the anonymous evaluation to share your feedback. If you would like to receive a certificate of completion, be sure to also complete the attestation. Links to both surveys are available in the description of this video. Your input is much appreciated.